Good evening, everyone, and welcome to another hour of Healthy Conclusions, where we try to give our listeners important information on nutrition, exercise, and holistic, alternative, and integrative medicine. Please take a minute to visit our website, www.healthyconclusions.com, and like us on Facebook. My name is Bob Neugebauer, and I will be your host for this evening's show. Tonight's show is being brought to you by Altrua Health Share, which has been serving its members and their families with their health care needs since 1997. Please take a moment to visit their website at altruahealthshare.org or call 888-244-3839 to see just what Altrua Health Share can offer you and your family for their health care needs. It could mean substantial savings. Our guest for this evening is Dr. John Livingston, a retired surgeon in Boise, Idaho, who is affiliated with multiple hospitals in the area, including St. Alphonsus Regional Medical Center and the Treasure Valley Hospital. He received his medical degree from Ohio State University College of Medicine. John has been a good friend over the years, and we are very happy to have him here today to discuss with us Medicaid, which is pretty much becoming a more serious problem as the costs continue to rise and we don't seem to be able to get people healthy. So welcome, John. It's a distinct pleasure to have you here in Healthy Conclusions. You've been someone from the medical field who has been involved in Medicaid system for quite some time, and if I'm not mistaken, at our last meeting, I believe you were expounding on the subject of how, from a cost standpoint, it was just about impossible to run a private medical practice anymore and make money doing it. So let's start off with, I think we are all aware that the healthcare system in this country is more screwed up than most would like to admit. But over the last 8 years, with Obamacare in and out, we seem to be in a substantial dilemma as to how to proceed in the future. Could you give our audience your perspective on how you would envision our healthcare system if you were given the power to change it?
Last time when I was here, which was 8 years ago, I discussed the fact that from an economic point of view, Obamacare was unsustainable. And the reason I mentioned that was because the incentives, the economic incentives inherent in the program were such that aggregate supply, the number of providers contracting for services, was going to go down. This, in fact, happened with the accountable care organizations, the consolidation of providers and insurance networks, and the consolidation of insurance networks themselves. The second point was that aggregate demand would go up. In every situation, in every economic situation where aggregate demand goes up and aggregate supply goes down, costs and prices go up. That's exactly what has happened over the last 8 years. If you look at the bending of the cost curve that Obama promised us, there was actually a bending of the curve that started in 2001, long before Obama even came Obamacare even came into being. As soon as Obamacare came into being and Medicaid was expanded and the expansion of health services increased through the exchanges and through Medicaid, the costs of health care have gone up dramatically. That cost curve is bending in the wrong direction, and it's bending in the wrong direction because of the Affordable Care Act.
So how do you solve the problem? How do you bend it back the other way? What are the key measures that have to be addressed before we can do this?
So let's look at what happened over the last 8 years. 8 years ago, we were told that there were 48 million people that did not have insurance coverage. Today, we have about 20 million people that don't have insurance coverage. So we've cut that number of people down by about 20 million people. 10 million of that group are people that have been covered on the exchanges, and about 10 million of that group have been people that are covered with Medicaid expansion. But most importantly, look what's happened to the cost of health care coverage in those states that expanded Medicaid. The cost of health care has gone up dramatically in those states. And to say that the reason we spent $1.2 trillion over 8 years to cover another 20 million people, and there's almost 30 million people that are still uncovered. So there's a couple issues involved. The first one is, let's look at the states that did not expand Medicaid. And the one I'm most familiar with, and I'll use an example, but it's true for all the other states. South Dakota is another example. Texas did not expand Medicaid. What happened to the number of uninsured people in Texas? The number of uninsured people in Texas dropped from 27% down to 16%, 11% without expanding Medicaid. Why? The unemployment rate went from 9.8% down to 4.2%. People had jobs, and with their jobs, they also got the health insurance benefit from their employer. That's number one. Number two, it's important to understand that in those states that expanded Medicaid, they grossly underestimated the increased costs of services, number one, and number two, and just as importantly, the number of people that would be covered. And they underestimated it by over 100% in almost every case. So the costs went up.
Now, the reason the cost went up, is that because there was pressure on the system with too many people seeking too few services?
Yes, that's exactly right. As demand increased, costs went up.
So as you have more employers, I would think that even if you have more employers offering benefits, that in those states, why wouldn't you see the same rise? Is it because they're paying for it in some way and the Medicaid people are not? Why? What is the difference there?
I'm at a loss to figure out why the carriers are not negotiating good rates for their customers. The amount of cost savings that the carriers could have, I think, are being grossly undervalued. And I'm very uncomfortable with the financial transaction between carriers and providers.
Well, I can give you the reason for that. They get 7% of whatever the cost is for a policy. Well, the higher the cost of the policy, the more money they're going to make.
That's exactly right. They're incentivized to sell more expensive policies. And that is the problem with the exchange. Is 8 years ago, I felt the exchange and people that would be buying coverage on the exchange, it would be a transition period for a lot of young people. They could go from getting premium tax credits to becoming employed and buying their own insurance policies. That kind of churn that was anticipated and promised to us by the Obama administration has not occurred. The thing that's also concerning to me in this state, and I should have mentioned it earlier, is the fact that we have no idea about the number of people that have bought insurance policies on the exchange with advanced premium tax credits that previously had commercial insurance. That could be a fairly significant number. If there's 100,000 people on the exchange right now, maybe 20 or 30,000 of those people had commercial insurance.
Now, when you say commercial insurance, explain that.
Commercial, either insurance through an employer or individual insurance that they bought themselves.
Okay, well, we know that for a fact because we've seen how many people were thrown out of their policies and had to go to the exchange. And I believe the number was somewhere in the neighborhood of 30 or 40,000. It was a huge number.
I have asked for that number to be presented to me, and I've been told by both the Department of Health and Welfare and by the insurance carriers that they cannot come up with that number.
They don't want to come up with a number.
I think that may be it.
And I think when you go back and you take a look at why these young people don't want to get involved with insurance, most of them feel like they're invincible at their age. And they don't feel that they need that kind of coverage. And if they do want coverage, they want catastrophic coverage, which was not offered. So therefore, you have this huge gap between you get all the coverage or you get no coverage.
And so when we start looking at insurance, what is insurance? Insurance is a financial tool that mitigates against the downside risk, in the case of medicine, of a medical catastrophe having a future claim on your family's earnings or wealth. That's what it is. Nothing more, nothing less. So this will get us into maybe our next segment. What they're trying to do with insurance today is to make there's no catastrophic coverage offered except there's two catastrophic plans that are offered on the exchange, and I think there's only 60 or 70 people that bought them. But they're promising it's more like a warranty instead of an insurance policy. They're wanting to ensure wellness and health, and their argument is if we ensure wellness, there will be fewer sick people in the future. And that statement, and that's what everybody has clung to.
We're going to have to take a quick break. We'll be back in a few minutes. You're listening to Health Conclusions on 580 KIDO. We're speaking with Dr. John Livingston, and we're sponsored by Altrua Health Share. Welcome back to Health Conclusions on 580 KIDO AM and 107.5 FM. We're speaking with Dr. John Livingston, and we're talking about Medicaid. We are sponsored by AltruaHealthShare.org. So, Doc, you were talking about the catastrophic insurance and how it just doesn't seem to be a viable entity within the framework of what we're doing right now. How do we get it there?
Well, part of the problem has been, and looking at this for the last 8 years, these policies that cover from the very first dollar or from just low deductible policies are nothing more than ways for the large providers and the large insurance carriers to be subsidized. And historically, and in fact in my own practice up until 2008, and there was a study done by the American College of Surgeons in 2005, and for general surgeons and neurosurgeons, 35% of the care that they rendered prior to 2005 was charity care. And I remember being on a panel with Max Baucus at Big Sky, Montana, and I mentioned this to him. And I said, hey, have you guys counted the amount of free care that all physicians give to patients as you calculate the cost of what Obamacare is going to cost? And that was in 2008. And he said to me, I'll never forget this, he says, just think, you'll be able to recover all that money that you're not getting now. That's what he said. He didn't get the fact that this was a tremendous service to society, that 35% of what I bill for, I wrote off the books. And they were indigent patients, they were Medicaid patients, they were, and as today, I wasn't allowed to balance bill.
Does that happen today? I mean,
No.
I don't think so.
No. So let's say you're a doctor today, and you're employed by a hospital, and you decide to waive your fee for service. Is it your charity that you're giving away, or is it the hospital's largesse that you're giving away?
The hospital's going to take credit for it.
That's right. Well, they do, because
Yes.
you're going to get paid anyway.
Right.
There is no charity care for an employed physician. They may think in their heart that there is. It's kind of like a politician that says, I'm going to give you a Medicaid policy, and I'll take care of you. That's not their charity. That's somebody else's charity. They didn't earn that money. That's not the fruits of their labor. That's not an invoice that they're not going to get to bill for.
Well, do you think the failure of the exchanges all around were pretty much due to the insurance companies pulling out because of what was happening with Obamacare in terms of the cost problem? Or do you feel that this is something that had to do with the younger people just not buying insurance, period?
So let's first of all talk about the success. Our Idaho exchange has been very successful. Why? First of all, it's been run like a business, not like a government agency. And we've had very good people running our exchange. But the most important part of why we've been successful is our clientele, our customer base. The people of Idaho, even in my practice of 30 years in this state, will do anything they can to make sure that their health care provider is reimbursed. I retired 4 years ago, and I'm still receiving payments through my booking company, $10, $20 a month, of people making sure that they'll pay off their debt. That's the mentality of Idaho people.
But that's very unusual.
Not the rest of the country.
Right.
So when we say that we've had a successful health insurance exchange, we have to say two things. We have great customers who are responsible people. They're Idahoans, and they're not looking for charity or handout. Number two, we've had great business management. That's why we've been successful. Almost every other state that I can think of, many of the exchanges have gone bankrupt. Many of the exchanges have had to be refunded by their state legislators. That's because everybody in those states is on the dole. So we've been lucky. We have good people and good management. I think I look forward to our exchange. I look forward to a phasing out of the advanced premium tax credits, maybe over 5 years, over 20% phase out every year, and then letting private insurance products be sold on the exchange. It'd be a regular exchange, just like any other exchange. And the exchange could be run by the private sector, by the insurance brokers that sell those products. Just by creating a new marketplace, that will help lower prices.
Oh, I don't disagree, but you need to bring in out-of-state companies. And also you have a situation going on right now where a company like CVS, a drugstore company, is now trying to buy an insurance company. Insurance is going to become very much more of a commodity. And it's going to be offered literally by Walmart, by Walgreens, by CVS. They eventually are going to get into the insurance business because they see the viability and the fit. Not only that, they can handle the electronics much better in terms of medical records.
So I think the more players, the more buyers, the more sellers you have in a marketplace, the more you are better able to approximate a true equilibrium point. Prices will go down. You have lots of people buying in the marketplace. You have consortiums of people buying in the marketplace. But if you have one or two insurance companies controlling a single market, prices are going to go up.
Well, didn't we have that here for some time? You know, I remember going back to the exchange days when we were battling back and forth, you and I, and we had our big debate party. But what my conclusion was is that when you take a look at the two primary insurance companies, which were Blue Cross at that time and Regence Blue Shield, they pretty much had 80% of this business locked up. Now all of a sudden, St. Luke's takes over Select Health, and it was supposed to be an experiment that they've never had any experiments with.
That was not an experiment.
Of course not. That was to get their own insurance company within the hospital. I mean, that's a big farce as far as I'm concerned. But how do you get a place like Idaho that has been ruled with the in-network doctors controlled by these insurance companies to expand and allow other insurers to come into this marketplace? I find it very difficult to do.
I'm certainly not an insurance expert. I've spent 8 years and I've had carte blanche access to the Department of Insurance, Director Deal and Director Cameron, and I appreciate that. I think there needs to be a mechanism where, and I think allowing out-of-state insurers to come in and sell insurance in the state, there's still a place for the state regulator, the director of the Department of Insurance, to review those policies to make sure that we're not getting sham companies coming in to sell it. We need to look at their financial status, their loss ratios, their past track record. But the more companies we have selling in the state, the more choice there is, prices will go down. Very important. Now, there's the issue, and this is what's so disturbing to me, is pre-Obamacare, we said that the key to this problem was integrating risk pools. Everybody in big risk pools, and that'll lower prices. That didn't happen. That only raised premium prices.
Because the young people did not sign up, and they did not reduce the risk.
That's right. But not only that, now they're telling us that we have to segregate risk pools. We have to separate out the sick people from the non-sick people. I think that the number of people in that segregated sick people risk pool is very, very small. It's certainly not 80,000 people that they're saying with Medicaid expansion. I think that number, and I don't know, is between 3,000 and 5,000 people.
See, and I believe just the opposite. I think it's more like 100 to 150,000. And I'll tell you the reason why. It's because most of the people on Medicaid do not complain, do not talk about the diseases or the problems that they have. And if they don't talk about them and they don't have issue with them, you don't know about them.
There's certainly about 50% of people eligible for Medicaid that don't sign up. We know that.
Right.
But that doesn't mean that those people have chronic diseases to preclude them from working. They may have rheumatoid arthritis and they can't use their hands, but there may be something they can do. If you're a surgeon, there may be physical limitations to what you can do, but you can do something else. So my point is, I think that as far as Medicaid is concerned, the current Trump administration is moving in the correct direction. I think they're moving to take Medicaid away from being an insurance system back into being a welfare system, and that's where it should be.
Well, are you talking about the pay to play?
I'm talking about work.
If you want Medicaid, you need to work.
That's right.
I agree. I don't think that that's something that's too onerous. But when you take a look at the Medicare problems that we have here in Idaho, surely you can agree with me that we have approximately 230,000 people currently on Medicaid. And if my numbers are correct, we could have as many as 330,000 had we expanded Medicaid.
I agree.
That would be 20% of the population. That's a huge number, and that is insurmountable in terms of how much it would cost the state. It would bankrupt us. We're going to have to take a quick break. We'll be back with Healthy Conclusions on 580 KIDO AM and 107.5 FM, speaking with John Livingston, sponsored by Altrua Health Share. Welcome back to Health Conclusions on 580 KIDO AM, 107.5 FM. We're speaking with Dr. John Livingston, sponsored by AltruaHealthShare.org. And our topic for conversation this evening is Medicare and insurance in general, I would say.
Medicaid and insurance.
Medicaid, excuse me.
So before we left, there was one point I wanted to make, and that is that I think that the cost of Medicaid, and if you look to Ohio, a state I'm very familiar with, if you look to Medicaid, by trying to cover too many people, we will place the lives of those most on the margin in the greatest jeopardy.
I think John Kasich found that out.
John Kasich found that out. And we found that out in 2011 in Idaho. We had to cut back Medicaid in Idaho. And it wasn't the young and healthy that were cut back. The services that were cut back were for those people that were the most infirmed and those most on the margin. So we got to always make sure that we recognize and take care of that number of people, which is far smaller than taking care of the young and healthy and providing them with an insurance tax credit.
I don't disagree with you, and I think that, even in the Governor's State of the State message talking about the amount of jobs that were added in the medical industry in our state were just unbelievable. But when you consider the fact that we are really short of doctors and we're short of practitioners in general here in this state, in fact, I think we rank 49th, if not worse, if you could be a little worse. Yeah. How do you solve that problem? And I agree that if you don't solve the problem, things are going to get worse. Whether we expand Medicaid or Medicare or we don't, it doesn't matter. Things will get worse unless we have more practitioners and more physicians working with the patients.
So that I agree with you 100%. And when I talk about the large hospitals, I want to be very clear. I'm not talking about the doctors, the nurses, the technicians that work there. We are blessed with a great workforce in this community of practitioners. I'm talking about the way the hospitals are run as businesses and their business models. So that's what I'm critical about. I think that it's very important to state up front that we have already expanded Medicaid in this state. Since Obamacare started, we have 25% more people on Medicaid today than we had when we started. That's 25% more. In the states that expanded Medicaid, that number is 106%.
Yes, I've seen the numbers.
And so that is problematic in Idaho, as you mentioned, because of providers. So some things about providers. And the people in the primary care community aren't happy with me when I do this or say this, but here's the deal. I think that we ought to extend the credential for family nurse practitioners and physician assistants to be able to practice independently, family nurse practitioners can, in rural communities. We can have physician assistants in rural communities that would be very helpful to getting medical outreach into those communities. The second thing I think we can do is what South Dakota is doing, and they're forming compacts with other states for licensing, for medical licensing. If you have a license in South Dakota, you have a temporary license in Idaho.
Right, they do a reciprocal
and
get started.
And you can get started on that process. So what licensing has happened in the medical profession, particularly in Idaho, and this needs to be addressed by the State Board of Medicine, is licensing has become a barrier to entry, just like it is in any. If you're a hairdresser or a contractor, licensing has become a barrier to entry, and because of that significantly causes prices to go up because there's fewer supply. So that's one of the many things I would do. If you ask me my fix, the first thing I would do is I would not expand Medicaid. Not expand Medicaid, not because I don't want to take care of people, because I want to take care of the sick people. And by expanding Medicaid, we put them in jeopardy.
Oh, I don't disagree with you. I think that's very true. I've been saying for years that we are not running a health and welfare program in Idaho, but a sick care and welfare program where we never seem to hold anyone responsible either on the patient's side or the doctor's side for the results of treatments given. Why is that? And how do we change the system so that we get some accountability?
Boy, I'll tell you what, accountability is a big deal, and we're seeing it now in the opioid crisis. Where is the accountability of the medical profession regarding their contribution to that crisis?
A great point.
I am a doctor. I'm proud of being a doctor. I'm proud of my physician colleagues and what they do and their sense of service. But we are a big part of that problem. And I've seen very little accountability and responsibility regarding that. Very little input from the American Medical Association. I haven't heard very much at all from the Idaho Medical Association about the opioid crisis we have in this state.
Well, they're saying we only have 240 some odd people who die from opioid each year in Idaho, which is not a significant number, but how many are actually becoming addicted?
How many families are destroyed by opioids?
A lot. Too many.
And how many people end up in mental health clinics and in drug rehab programs that are a cost to society? That's a big deal. Nobody
wants to understand how much it costs society, but the drug companies just keep pumping them out, and the doctors just keep prescribing them like they're candy.
That's right. That's exactly right. You know, it's interesting. In Japan in the late 60s and early 70s, there was no control of there were no controlled substances. You could go to the drug counter and buy heroin or buy cocaine or buy any opioid that you wanted to buy. There was a sense of accountability and responsibility within the culture of Japan that abuse was almost unheard of. As Western mores came to influence their culture more and more, drug use became more and more of a problem. So in the late 60s, if you were a drug addict, this will sound cruel, you were shunned. Your family turned their back on you, and it was up to you to get your life back together. Now, there's all kinds of rehab programs and everything else.
Support groups.
Support groups.
Sure.
These work. Alcoholics Anonymous is fantastic.
Now, I've seen it work with my brother.
It's worked well. But any government program that tries to model itself on Alcoholics Anonymous will not be as successful because there's not the required individual responsibility and accountability within the group.
See, and that's where I find the big problem with the Medicaid system is that there is no accountability. And unless you can get people to understand that they're sick because they want to be sick, because they allow themselves to be sick, and they don't want to take care, and they don't want to understand that you need to have proper nutrition, you need to have proper exercise, and you need to understand that you have to have a healthy lifestyle. And most of them don't get that. And we don't encourage that with a SNAP program that allows them to go out and buy any kind of garbage they want from the stores. And mind you, almost everyone who's on a Medicaid program is on a SNAP program.
Absolutely.
And if you were to change that and say, okay, if you're on a SNAP program and you actually start a wellness program to get yourself better, and you improve your health in the next 3 months, we'll give you more money so you can go buy organic food. There's a way to incentivize people, but nobody's looking at it.
Well, I think that the SNAP program, there's all kinds of problems with it, but the bottom line is that there should only be certain commodities available, food products available to people on the SNAP program. The SNAP card is actually a form of currency. It's used in the black market to buy drugs. Here's an interesting fact. In those states that have expanded Medicaid, the opioid drug crisis is twice as great as in those states that haven't. And all you have to do is look to North Dakota that expanded Medicaid and South Dakota that didn't, and look at the opioid drug use.
Well, you know, there's a reason for that, and I've looked into this, and I've done a lot of studies on this. And the reason that they're coming up with in pretty much all of the cases is that the docs that are getting these chronic pain problems. Now, anything can be categorized as chronic pain. I don't care what it is.
I have chronic pain.
Okay, yeah, I have a chronic pain sometimes with the politicians. But my point is that you can classify it all as chronic pain, but they're not trying to solve the root problems or the root causes of these people's problems. And they treat the symptoms, but they never treat the root cause of the problems. And that's where we have to get to, where the physicians are responsible for actually finding out what's wrong with somebody instead of just handing them a bunch of pills. Because they get a bunch of pills, they take them. Next thing you know, they're back. They say, hey, I got another pain, and this is what it is. And they give them another bunch of pills. And next thing you know, the guy has 7 prescriptions. You're listening to Health Conclusions on 580 KIDO. We're speaking with Dr. John Livingston, sponsored by Altrua Healthcare. And we will be back in a few minutes. Thank you. Welcome back to Health Conclusions on 580 KIDO AM, 107.5 FM. We're speaking with Dr. John Livingston, and we're sponsored by Altrua HealthShare. Our subject this evening is Medicaid. So, John, let's continue on where you were before. We have a problem here in Idaho. I understand that the governor is making a play to require $17.4 million from the general fund and another $11.4 million from the Millennial Fund to help Idaho citizens who actually get less help with coverage under the so-called Affordable Care Act to be able to purchase and have insurance. How do you think that's going to work out? Taking $30 million more of our tax dollars and putting it into what I would consider to be private health share.
I think that money would be far better spent taking care of sick people rather than trying to subsidize the care of sick people with an arbitrage construct so that we're covering young and healthy people to offset the cost of the sick people. That's not the way to do it, because sooner or later those credits or that government support is not going to be there. And when it's not there, the sick people are going to be hurt.
Well, and the other thing is, this is just shoveling more money into the insurance companies. And I think I'm kind of tired of seeing that happen. We've shoveled enough in there over the last 4 or 5 years.
I think getting more insurance companies selling insurance will solve that problem by itself.
Well, that's definitely going to happen in the future. I wanted to get back to this chronic pain mantra that everybody is still clamoring about and the opioids. It's been suggested by 37 attorney generals that have sent a letter to the various insurance companies that run these plans that they want to see integrative medicine brought in to deal with chronic pain, because there doesn't seem to be another method besides the opioids to deal with it. And they're pretty much convinced of that. Now, if that happens, and also the company, the organization that rates hospitals has said they want to see integrative medicine brought into the hospitals that they rate every year so that they can deal with the chronic pain. So this is forcing an issue, and it's bringing it to light. How do you feel about this?
So the JCAHO, the accrediting organization,
Joint Commission on Accreditation, Healthcare.
I'm not a big fan of the JCAHO. I don't think they do a good job of identifying either clinical or business issues within a hospital. let me just say this. It was the JCAHO in the mid-'90s that came up with the so-called physician or the patient Bill of Rights. And they published it, and they told all their hospitals that they were going to inspect, that they were going to use this as a standard for whether or not they passed their inspection. One of the issues on the patient's Bill of Rights was this, and I quote, "Patients have the right not to be in pain." That was promulgated by the JCAHO. So the JCAHO is part of the problem. You can't guarantee somebody that they won't be in pain. But that was going to be a criteria by which clinical services were judged. So doctors started wanting patients to be satisfied, giving more and more pain medicines. This is in the early to mid-'90s. And that, I believe, was part of the genesis of our current drug problem and the physician-caused opioid crisis that we have in this country now. So I think that there needs to be identified specialists that handle pain. I think a doctor giving 30 oxycodone or OxyContin after a single procedure, for total hip, for example, that's fine. Beyond that, you should send that patient to a pain specialist because there's other things you can do for pain. Acupuncture.
Right.
These other things that are available to a specialist.
Well, the veterans have been using these alternative medicines for years, and they've had great success. I've looked at the surveys.
I think that's right, and I think the military has been doing the same thing in their physical therapy departments. I know when I go down to Fort Sam Houston, I see when I go on a ward, a post-op ward at Brooke Army Medical Center, I see TENS units. Every single patient has a TENS unit, a electrical stimulator. I'm seeing them more now on the wards in the private hospitals. There's other ways of handling pain. But to create the expectation that a patient has the right not to be in pain, that's problematic. There's nobody that has the right not to be in pain.
Well, and the problem is that many of them create their own pain by not doing what they're supposed to do to relieve the pain. And
That's
we've
right.
seen that time and time again. You can give somebody the prescription to get well. Whether they use it or not is entirely up to them. And that means you have to have responsibility and accountability.
And in that regard, it has to be said, I've made some bad comments about, some not so nice comments about my physician colleagues, and me included. I've probably overprescribed in my career at one time or another. But there's also people that use their pain not to get better.
I don't doubt that either. And a lot of them, they don't want to get better. They don't want to go to work. They are those dropouts. And they are the 10 to 12% in the Medicaid group that you're never going to change.
That's right.
But there are the rest of them that can be changed. And, you know, again, it depends on how you go about doing this. You have to do this in a way that's going to cut costs, that's going to give people more freedom of choice, and that's going to give them an opportunity to actually find out if they can get well. Because the way we're doing it now, nobody seems to be getting well.
So here's the other point, is there's been a big consumerism has crept in here into the, and institutions, doctors, clinicians are given report cards and their patient satisfaction. And JCAH comes in and looks at your patient satisfaction forms. Well, in 2014, the American College of Surgeons, in the Annals of Surgery, did an article trying to correlate patient satisfaction with outcomes and complications. And they did a scattergram as one of their main tools to demonstrate there is absolutely no correlation between patient satisfaction and clinical outcomes. So if a doctor is trying to please a patient and give them more drugs, that's going to create a bad clinical outcome, not a good clinical outcome. And so we need to get out of this idea. Boy, I'll say it again. There is nobody that has the right not to be in pain.
Well, let me go back, and as I was saying earlier, that you kind of correlate what's going on with opioids, I correlate it with what happened with cigarettes.
Sure.
And we saw what happened with cigarettes, that eventually the government says enough is enough, and we're going to come down on the cigarette manufacturers, and we're going to curtail their advertising, and we're going to slow down the way they sell them and how they sell them and how much they sell them for, and we're going to tax them to high heaven. They haven't yet come down on the drug companies, and I don't know whether you watch a lot of TV, but you're going to see I don't care what station it is, you're going to see drug commercials on every 20 or 30 minutes. And the fact that they have a drug person from a particular company on every major media board except CBS, all right, tells you something about how they are pushing this to get people to buy specific drugs, not even knowing all the complications.
Well, that's the other thing is direct marketing to patients has been part of the consumer movement, and they've said that it's part of the transparency movement. Nothing could be further from the truth. This is adding utility. This is creating costs. This marketing, a patient comes in, sees a TV commercial, talks to their doctor, and they say, I want what's on the TV commercial, even though it costs 10 times more.
Right.
So here's this. So I want this. The doctor says, no, this is just as good. No, I want this. Well, I'm going to give you this. Well, the doctor gets a negative rating on the patient satisfaction form. JCAH comes in and looks at the patient satisfaction form and says, this is a bad doctor. The patients aren't happy.
Right.
This is not the way to do things.
Well, of course not.
And so it's been frustrating. And what we've seen here is a complete loss of the doctor-patient relationship. And
well, that's because of third-party payments, too.
Well, sure. Absolutely. The financial transaction is separate from the clinical transaction. And so, again, I think that the solutions to these problems are found in the free market. I don't think government has any way of being able to solve these issues. Command economies don't work. If you think they do, just look at the VA, look at the military healthcare system, and look at the Indian healthcare system. They don't work.
Doc, I think we're going to continue this on in our next session. We'd like to thank Dr. Livingston for joining us this evening and for offering his insights into Medicaid. This is Bob Neugebauer saying goodnight for Health Conclusions. We hope you'll join us again at the same time next Sunday for another hour of informative talk on nutrition, exercise, and alternative medicine options, sponsored by AlchuaHealthShare.org on 580 KIDO AM and 107.5 FM.